I'm looking forward to having a great session where we are going to learn. My name is Dr. Lusweti Victor. I'll be the moderator for the day. So just something brief about the format of today's session. We are going to have a talk by Dr. Mordicai Atinga. Then during the talk, I encourage as many of us to post questions, okay, on the chat. Then the speaker will respond to the questions after the presentation. Then lastly, we'll have a brief presentation from our sponsor, which is Stroker. So I'd like to take this opportunity to welcome Dr. Mordicai Atinga, who is going to do a presentation on chondromalacia of the patella. Karibu, Daktari.
Thank you very much. I'm really sorry for my tardiness, but I was having some tech problems here, but I think we're now up and running. Can you guys see my screen? Hello, can you see my screen?
Yes, we can see the screen.
Okay. Okay, fantastic. Let's get going. So I wanted to just talk about Patella Chondromalacia or patellofemoral pain, which is something we see very frequently in most orthopedic clinics. I think management is fairly straightforward, but once in a while, it's not the usual standard presentation, and it's always nice to have options and being able to think outside the box. I'm currently working at Aga Khan Hospital. My background is fellowship trained in shoulder and knee surgery. So in terms of Patella Chondromalacia, it's a bit of a catch-all term. Like I said, it's used to mainly refer to patellofemoral pain. In classic texts, it was described as inflammation and softening of the cartilage, which led on to pain. I mean, the association with patellofemoral chondromalacia that we think about is this damaged cartilage. You're looking for abnormal alignment, and normally it's a combination of those two, with most likely abnormal alignment leading to the damaged cartilage. Now, when you're looking at etiology, I guess the two things you want to know are whether the patient has, like I've mentioned, normal alignment or not. In someone with normal alignment who comes in with anterior knee pain, the question you're wondering is whether there's been a traumatic event that has led to the cartilage damage, and that is now what is feeding the ongoing problem. It's also been mentioned that in patients who come in to see with normal alignment, it's worth looking for bipartite patella, especially if there's any instability in the unfused segments, which typically then lead on to increased lateral pressure. Abnormal alignment is where it gets interesting, and again, most often these patients will present with increased loading laterally, but the presentation is never that clear. They have pain that can be medial, it can be on the joint line, and it can mimic a host of other pathology inside the knee. In terms of things you'll be looking out for, you want to assess their Q angle, you want to find out if they're weakness or PMO, and you're also looking at rotation. There's from the proximal going down, you're looking for anteversion, you're looking for valgus, you'll be looking for tibial rotation, and whether they've got planus foot, which in itself can mechanically lead to external tibial rotation and abnormal loading. So on the examination, you want to find those patients who've got, the classic text again, miserable alignment. And these are the rotational deformities. that I've mentioned. Sometimes these can be subtle and dynamic. So, if someone is standing still, you can't see anything obvious. But once they start walking, that's when, muscle weakness leads to, a valgus thrust of the knee, which in itself creates torsional forces that will force the patella laterally. And the obvious one that we always check for is the valgus knee, as I've already mentioned. In assessing rotation, I think that we can be thankful for the pediatric texts. A lot of them, these very same examinations apply in the adult. On your left, this is how you'd want to assess for external tibial torsional rotation. You have the patient lying prone on the bed with the knee bent at 90 degrees. And then you're looking at the angle of the foot relative to the thigh. And anything more than 30 degrees, I think would be abnormal. Obviously, this is within a range. For the assessment of femoral anteversion, it's the picture on the right, where again, you have the patient lying prone on the bed. The important thing is to have your hand feeling the greater trochanter, and as you move and as you internally rotate the hip by externally rotating the tibia, you're feeling for the point at which the greater trochanter is most prominent. And the angle then is measured from the end of the bed, and you're looking at how internally rotated the hip is relative to a vertical line. Valgus of the knee is normally clinically obvious, and you can see the way the patient stands. In more subtle cases, you can perform these long leg films, and you're looking on the picture on the right is, strictly speaking, looking at the mechanical axis, but measuring the Q angle, you're looking at the line from the ASIS at the midpoint of the patella to the tibial tuberosity. And again, there's a range of normality, but someone over 20 degrees, you're beginning to be worried, especially if they present with anterior knee pain. The typical investigations, you start off with x-rays as always, and it's important to get the Skyline view, because that's where you get the most information when considering what to do next, and indeed even the diagnosis. MRI scan is useful when there's no obvious malalignment or rotational deformity that you can pick up, and you're then looking for damaged cartilage. That could again be the scenario where someone has normal alignment but has had a traumatic event, which will be shown on the scan. The CT scan is probably the most useful in terms of assessing rotational abnormalities. To be honest, we don't frequently use it because clinically you can pick up a lot of the obvious deformities. But in terms of surgical planning, it's an extremely useful tool that will help you, one, work out where the deformity is, and particularly combined deformities where there's both anteversion at the hip and external tibial rotation. And just an example there, Skyline view, obviously it's that tangential X-ray shot with the knee flexed about 45 degrees, also called the merchant view. And this particular image here shows what a perfectly aligned patella to the trochlea would look like. The MRI scan, like I mentioned, is very useful when looking for damaged cartilage. So the picture on the right is fairly obvious because you won't miss those cysts in the patella, which tells you that there's been ongoing damage in the patellofemoral joint. The picture on the left is slightly more subtle, and this is easily missed if you're not particularly paying attention to it. If you look at the medial patella facet there, you can see the articular cartilage is slightly lighter. It's a lighter gray color, and that is a very typical picture for Patella Chondromalacia. And this picture here is just showing you where the CT imaging can come in handy. So, you can measure the anteversion relative to the posterior femoral condyles, which you can use as your 0 point, and then you scroll and see how much anteversion there is present. And then equally, again, using the proximal tibia as your 0 point, you can then measure how much external rotation of the tibia the patient has. In terms of the early management, it's rest, activity modification. There's some mounting evidence that using orthotics, especially in patients with planus, yields good results. Physiotherapists are very good at using taping, which is always a useful intervention, although I normally think it's slightly short-lived just because of the forces that are involved. But obviously, if it's part of a program where you're strengthening your VMO and the like, then taping is an extremely useful tool. And then pharmaceutically using NSAIDs and steroid injections when patients are having a particularly bad time. Normally, that's where it ends, and you will not see those patients again. And sorry, I should have added weight loss there, because weight loss is extremely important in managing any patellofemoral joint problem. And that is one of the conversations you must always have with patients who come to you with anterior knee pain. Most of the time, those measures will deal with problems, even those that are more advanced with more complex rotational deformities. So you must focus on conservative management, and if it fails once, you go back and do it again before you start contemplating surgical options. And the actual focus of my talk was really to just give you guys some of the options, and I'm not giving you answers, but it's just a framework that you can use to think about patients you see who come in with recalcitrant anterior knee pain. So before you consider surgery for patella chondromalacia or patellofemoral pain, you must understand the mechanics and the etiology of your particular patient. You want to look at what the malalignment is, and this is where the Skyline views come in handy. Does the patient have lateral tilt? Is it a lateral riding patella, or is it both a lateral riding patella with tilt? And obviously, the other questions that you must consider as well is whether they have come in on the back of a history of something like a patella dislocation, where they have abnormal alignment, and in the course of the dislocation, they have then damaged cartilage, and that's why they're now having symptoms, whereas before they had pre-existing problems that were not particularly symptomatic. You also want to look at rotational alignment, as I've said, and we looked at the ways of measuring it with the prone examinations, which yield the most information. But this is a useful picture for you to look at and to also think about the Q angle. There are times you can have patients who, standing in front of you, do not have a valgus deformity, but they could have an extremely large Q angle with a combination of anteversion, which they correct by internally rotating the femur, so the patella is going to be medially pointing, and obviously with the foot pointing forward, the tibial tubercle is more externally rotated, and so the Q angle is big. And if you imagine if that is combined with external tibial torsion, you can have a fairly large Q angle with someone who has got a fairly normal stance. This can further be compounded by ligamentous laxity, so that when they're walking, if you imagine this scenario coupled with a valgus thrust in their gait, they could have a dynamic situation where the patella is under, the patellofemoral joint is under extreme loads. So going into the surgical options, the easiest one, I suppose, and probably most unpredictable, is in the patient with a normal alignment and normal patella height, but with some patellofemoral chondral damage. The chondroplasty is not a bad option. It's basically going in, shaving any loose cartilage, gentle stimulation of subchondral tissue. I don't use microfracture on the patella, but some people do. The results are varied at best. I remember one of my mentors used to tell patients that there was a 70% chance of 70% improvement, which sounds impressive, but when you do the maths, that's 50-50. Then you can also have this situation where the patient has got isolated patella tilt. So if you look at the X-ray, there's no lateral translation of the patella. And in a patient who presents with anterior knee pain and has got this picture on the CT scan, no rotational deformity and anterior knee pain, and let me say anterolateral knee pain, there's a good argument for performing a lateral release in this scenario, and the results tend to be quite rewarding. However, that's an extremely narrow indication for using the lateral release, and most of the time it's not an operation that you perform in isolation, and if you get the indication wrong, you can leave your patient worse off with their ongoing anterior knee pain, but you've also thrown in some instability for good measure. So always assess everything from the top to the bottom, use your imaging, and then arrive at the way forward. In this scenario where they have patella shift and tilt, obviously the lateral release would not be a good option and would likely lead to further instability. Normally this scenario here is accompanied by a rotational deformity, and the patients frequently will also have Patella Alta. As you well know, there are many ways of measuring Patella Alta, and more frequently, such a patient must always carefully ask in the history if there's been any history of dislocation, as that Skyline view combined with the Alta output instability as probably the bigger problem. In isolation, Patella Alta, a couple of biomechanical studies, this one by Loix in 2009, a lab study showed that Patella Alta led to increased patellofemoral loads. Now that would become significant in an individual who comes to see you following some kind of patellofemoral trauma, because once you've had damage to your cartilage, your Alta now comes into play because of the increased loading. So you have more pain because this damaged cartilage is trying to heal in an unfavorable environment. For the combined deformities in those patients who have both patella translation, tilt, and Alta, I think if the symptoms warrant it, you can consider operations where you're shifting the tibial tubercle and also performing a lateral release. But the lateral release is just an adjunct to the realignment of the Q angle. And there are numerous ways of performing the TTTs, which is an extremely versatile operation in managing patellofemoral problems. The axial rotational deformities, so this is an anteversion, femoral anteversion, and external tibial torsion, are fairly complex surgeries, but in the right patient, very rewarding in terms of sorting out the mechanical problems. It's probably best done when these patients are young, because they have the best healing potential, and the areas in which you perform these osteotomies, particularly the distal tibia, you want to do it in someone who will heal and not leave you with a non-union. Carrying on with osteotomies, obviously the distal femoral osteotomy is a good option in someone who's got significant valgus that is mainly femoral in origin. These patients with valgus will have a fairly large Q angle, but if you perform the osteotomy, it restores the Q angle, and once the bone has healed, you hope you have a happy patient. Sorry, this picture is not very clear, but it just shows typical restoration of the mechanical axis and also Q angle. And as I've said, with the excessive femoral anteversion, the osteotomies can be performed distally or proximally. In young patients, the proximal osteotomies tend to be more commonly used, but there are clever intermedullary osteotomy devices that you can use that are fairly elegant solutions to these problems. In young patients, the distal tibial osteotomy and fibular osteotomy, I should have added, again, heal very well and allow good restoration of the rotational alignment. In summary, the Patella Chondromalacia or patellofemoral pain is extremely common, and most people have it. And I'm sure if we took a straw poll of the people in this forum, half of you have suffered anterior knee pain at some point. And so the management is conservative and conservative and conservative. Again, you want to focus on weight loss, quadricep strengthening, consider foot orthoses as well for those who are flat-footed. And it's important to perform a proper assessment to understand what the mechanical problem is. And for those who don't respond well to their conservative measures, you can then consider surgical options, but it's not for the faint-hearted, and I don't do many of these. Thankfully, simple measures work well here. I hope you guys have just managed to get something to think about whenever you see these patients with anterior knee pain, much as it's always physio, but a proper assessment is key, and that will help in further planning. Thank you.
Thank you, Dr. Atinga, for that presentation. That was quite informative, and I think it's given us a lot of insights on how to manage such patients. We have quite a good number of participants here today, close to 60. I believe we can raise a few comments, a few questions for Daktari to respond to before we proceed. Are there questions on the chat? Not yet. There's a question. Any comment on stem cell therapy? That is from Dr. Museve. Any comment on stem cell therapy, Daktari?
Oh, sorry, I got stuck on mute there. Stem cell therapy, it's a bit of a catch-all term sometimes, but I think with Patella Chondromalacia, the first thing is assessing alignment. Once you establish the alignment is normal and you've got a suitable mechanical environment, you could consider some kind of biological regeneration. I mean, at the moment, we don't have a lab in our region, as far as I'm aware, where you can harvest some chondral cartilage and send it for growth and then come back and do replantation. So it's academic some of the papers that I've looked at, if it's specifically damaged the patella, I think the results are varied. And again, most of them are performed in combination with a realignment procedure. So it's hard to tell whether it's worked because the mechanical environment has been sorted out, or if it's worked because they've managed to replace the damaged cartilage. But it's an evolving field, and at the moment, to be honest, I'm not sure. It's horribly expensive and still experimental. So I think if we are to do that, it has to be within the confines of an experimental situation where we're trying to get more information as opposed to saying it's a full-on treatment. I don't know if that covers the question.
Thank you for that response. I think Dr. Museve might ask some more questions if he has. There's a question when doing tibia tubercle transfer and lateral release. Do you also, I'm not sure what ref is, do you also ref the medial capsule? Are you able to read that question, Dr. Atinga?
Let me see. Okay. Yes, I can see the question. In terms of reefing the medial capsule, no, I don't tend to do that. Not for Patella Chondromalacia, because with Patella Chondromalacia, the problem is abnormal patellofemoral loading. My thinking is if you've sorted out the alignment problem and there's no instability, performing a tightening on the medial side runs the risk of adversely loading the patellofemoral joint. If you're doing this for instability, if someone is having recurrent lateral dislocation, then yes, the medial patellofemoral joint is part of the procedure, and you want to reconstruct. You want to reconstruct that. But for patellofemoral pain, I think what you're attempting to do is to reduce abnormal loads on the patellofemoral joint.
Okay, thank you. I've seen a few consultants who also deal with such patients, Dr. Mbugwa, Dr. Makoha, and a few others. If you have comments or questions, kindly. Okay. Any other questions? Before we invite our sponsor, what was his name? Edward. Edward, prepare as we wind up with the questions. Don't want to lock participants out from the questions, but it seems that we've exhausted the questions. Thank you, Dr. for that presentation.
Thank you very much. Thank you very much, Doc.
Thank you. Okay, there being no other question, I think I'll invite Edward from Troika to do a very brief, is it a talk or a presentation on their products? Karibu, Edward.
Asante sana, Daktari. Thank you so much, Dr. Lusetti, and also Dr. Atinga for the presentation. My name is Edward. I'm from Troika Pharmaceutical, and I'll just try to be very brief. As Troika, we are into pain management, and we have some few products. And just to highlight some few products, the first is Dynapa QPS. This is our diclofenac topical spray. QPS stands for quick penetrating solution. And the second brand is Zyka Extend. This is paracetamol extended release which has 325 mg as immediate release and 675 mg as extended release. And lastly, we have Dynapa AQ, which is diclofenac injection, 75 mg in 1 ml. This being the only approved IV diclofenac. It can be given as IV, IM, and also intradeltoid as IM intradeltoid. So just to highlight about Zyka Extend is paracetamol extended release, which is 325 mg immediate release and 675 extended release. So most of the time, paracetamol is widely used as a painkiller, and it's accepted as a first-line analgesics. And as being a drug of choice, paracetamol is known that it is much safer as opposed to any other molecule like NSAIDs. So paracetamol, most of the time, to give its therapeutic effect, is that it has the concentration of the plasma, it should be 4 microgram per ml. So that is the concentration, minimum effective concentration in the plasma that is required to give its therapeutic effect. So what happens generally in the current situation that we have 500 mg paracetamol and 1 gram paracetamol. So there is a lot of issues, most when it comes to frequent of dosing. Why? Because once you take paracetamol, within 3 to 4 hours, the MSC level paracetamol falls below 4 microgram per ml within 3 to 4 hours. So you have to keep on dosing. So as a company, what we have done is that we have developed Zyka Extend to ensure that we reduce this kind of frequent dosing, whereby for Zyka Extend, we have 325 mg and 675 in 1 tablet. So for the immediate release, 325 mg, once you take the tablet, it is immediately released to the system. It ensures that the MSC level is above 4 within the shortest time, therefore ensuring that there is faster onset of action. Then 675 mg starts being released. It is timely released for 12 hours. So while using Zyka Extend, this is the only tablet which gives you 12-hour protection from pain, whereby once you take the tablet, the MSC level paracetamol goes above 4, and 675, which is extended release, is continuously released for 12 hours. So it ensures that the MSC level of paracetamol is above 4 microgram per ml within 12 hours. And therefore, for Zyka Extend, you only need 1 tablet for 12 hours, as opposed to when you're giving 500 mg or the normal 1 gram, where you have to take up to a maximum of 8 tablets in 24 hours. So the advantage of Zyka Extend is that we are able to reduce the pill burden to the patient. Number 2, we are ensuring that there is no chances of recurrence of pain, because once the patient takes 1 tablet in the morning, he only has to take while in the evening. And lastly, paracetamol is known to cause liver hepatotoxicity when you are taking in high doses and for prolonged duration of time. So for Zyka Extend, you're only taking 2 grams. For the other paracetamol, you have to take up to a maximum of 4 grams in 24 hours. So Zyka Extend, you're only taking 2 grams and therefore reducing the concentration of paracetamol in the blood plasma. Even if you're taking for longer duration, there are no much side effect as compared to any other paracetamol. So Zyka Extend is available. You can take 1 BD. In most of the cases, you can also, what we are trying to do is that we are trying to avoid using oral NSAID in most of the patients, because you find that some of the patients have other maybe complications, GI irritations, that some have renal failures and the rest. So in those cases, when you're using Zyka Extend, it is much safer. And to avoid any kind, if you need a topical preparation, then we have Dynapa QPS. Dynapa QPS is a topical preparation which you can spray at the site of pain. And if you need an oral, then we have Zyka. So in that case, you can combine Dynapa QPS and Zyka Extend. Your patient is going to be relieved of pain, and therefore you're going to avoid all the NSAIDs and the side effect. And lastly, for Dynapa AQ, it is the only injection which is available as 75 mg in 1 ml. It can be used as IV because it has water as a base as opposed to propylene glycol. So Dynapa injection is the only diclofenac injection which can be given as IV infusion. You can give IV bolus. You can choose even intradeltoid because it's just 1 ml. So those are our product. And thank you so much for your kind support in most of our product. Our product, Zyka Extend, Dynapa QPS, and Dynapa Q are well available in all the institutions within Nairobi and other regions, Kisumu, Eldoret, Mombasa, and even up to Garissa. So I kindly request you to support Dynapa Q, Dynapa QPS, and Zyka Extend. Otherwise, thank you so much, KOA, for this opportunity.
Okay, thank you, Edward, for the presentation. There's an announcement. You are encouraged to participate in the polls. Kindly do so. Do we have any questions for the two presenters, Edward, Dr. Mordicai? Maybe if there's a question that was locked out, I can see Dr. Oburu asked a question, but I think it's been answered on the chat section. What are the costs, Edward?
Yeah, for Zyka Extend, it is very cost effective. For Zyka Extend, 1 tablet is around 25 shillings. So when you're taking 1 BD, that is 50 shillings within a day. For Dynapa QPS, the cost is to the patient. It now all depends, but our retail price, our recommended, our price to the pharmacy and to the hospital is around 620 shillings. Now, I honestly cannot tell between hospitals because they have their own backup margin, but the recommended retail price is 800 shillings for Dynapa QPS. And for the Dynapa injection, 1 ampule is 90 shillings.
Okay.
Yeah.
Thank you.
Thank you.
Any more questions? You are free to ask before we call it a day. No questions? Irene, do you have any announcements?
No announcements.
Okay. There being no questions and announcements, I'd like to take this opportunity to thank Dr. Mordicai Atinga for the presentation. That was a wonderful presentation. You are very audible. Your slides were perfect. Okay, we really enjoyed the presentation and we learned quite a lot. I also want to thank Edward also for the sponsorship. Okay, and Troika at large for the sponsorship and the presentation. Thank you, participants. Have a good evening.